at Mount Sinai, and my subspecialty focus and interest is in peripheral nerve. And I'm very excited to be here to talk to you about this topic. It's definitely a hot topic as we try and push the boundaries of what we can do for folks with spinal cord injury. Okay, so um, just by way of background, I'll give this talk, but we'll have questions at the end, I believe. But one of the disclaimers I'll have is that there are surgical pictures and videos in the presentation, so just some discretion advised if that makes you squeamish or what have you. But I find it very helpful and informative for patients and family members and everybody to sort of see what we do and how this translates to making a big impact for our patients. Okay, so let me move ahead here. I have no disclosures relevant to this talk. So our objectives today, just firstly, background, we'll go over just some basics of peripheral nerve injuries and repair strategies, because that'll be a helpful background and context for how we talk about nerve transfer, what nerve transfer is. We'll move into discussion about what principles are for nerve transfer and how we use them in nerve reconstruction. And then finally, we'll dive deeper into how nerve transfer can be applied for patients with spinal cord injury, to really optimize and even improve the level of function that we can offer. So just starting with basics of nerve injury and repair. So peripheral nerves, what are they? I know we've got a sort of a broad view of broad array of people in the audience, but we think of the nervous system as the central nervous system, our brain and spinal cord, and then the peripheral nervous system, as those signals travel out into the extremities and everywhere else in the body. And so the nervous system has nervous components to it, nerves, the yellow structures here, but also connective tissue. So the nerve is surrounded by protective fat and other connective tissue and blood supply and blood vessels that help keep it healthy. And these things are all good, but when there's an injury, they can turn bad if it leads to scarring or fibrosis or things that interrupt nerve signals. Now, over the many decades that folks have been doing peripheral nerve surgery, we've learned a lot about how these nerves work, what they look like on the inside, and very interestingly, we know the anatomy even down to inside the nerve fibers themselves. So this is a classic example of the ulnar nerve going down into the forearm and the hand. And the nerve fibers within these nerves travel in little bundles that we call fascicles. And that fascicular architecture is very preserved all throughout, even high up in the arm. So we are able to leverage this fact in surgery, like I'll show you later in this presentation. And that's really a key component for nerve transfer surgery, is that there are fascicles and nerve fibers that control different functions of what the nerve provides. So what happens when a nerve is injured? I won't dive too deep into the details, but this little schematic illustrates that after the nerve is cut or injured or severed, there's a very complicated process that unfolds called Wallerian degeneration as the nerve starts to try and prepare itself to heal. This is a key aspect of the peripheral nervous system that we don't see in the brain or spinal cord, that the peripheral nerves can regenerate and regrow. We want to use that strategy to that fact to our advantage. So initially, the nerve will kind of regress to the closest sort of node, and then there will be signals to help the nerve kind of regrow, supported by Schwann cells, fibroblasts, and other supportive cells that surround and help the nerve. You can kind of think of it like a trail of breadcrumbs. These cells have been shown to help guide the nerve to its target. We think of nerves doing three things: motor function, sensory function, and pain. And interestingly, in experiments, we can see that depending on if the fibers are supposed to innervate a muscle or a motor fiber or a sensory organ like the skin, these trophic factors can help guide the nerve to regrow to the area that it's supposed to reach. And briefly, for many decades, this is the way we've managed peripheral nerve injuries. We want to get a sense of how damaged is the peripheral nerve. Like I mentioned, just like that telephone wire, there are multiple fibers within the peripheral nerve cable there. And the severity of the injury just depends on, well, how many of these layers are violated. On the right-hand panel, if just the protective covering of the nerve is injured, but the nerve itself is in continuity, well, that's a good thing. The nerve can still send its signals. They might be slower, but they can ultimately heal as those protective covering regenerates. But if more of the nerve fibers are hurt or injured, or down here in a neurotometic injury, if the nerve is cut, well, that's a lot less favorable for that nerve to regenerate, and often we have to step in and help it recover by repairing it or grafting. To do this, we use a lot of adjunctive techniques and tests to help us understand how severe is the nerve injury. We use electromyography, nerve conduction studies, to try and assess how are the muscles responding, how are the nerves conducting, to try and get a sense of how injured the peripheral nerve is. And sort of, I like this table from Susan McKinnon. It sort of summarizes everything together. But based on how much the nerve is disrupted, and you can look on the right side, if the nerve and the nerve fibers are pretty much still in continuity, but some of that protective covering is hurt, well, that's a pretty good sign, and those nerves can recover pretty quickly quickly by our standards, within 3 months. But if there's more disruption of the nerve fibers, either within each bundle or even if those bundles are disrupted and scar tissue can form, well, then that process can be a lot slower. And for high grade injuries, we can tell on EMG and nerve conduction study that it's unlikely that that nerve is going to heal and we want to intervene. So like I mentioned, after 3 months or so, we sort of keep examining the patient, following them, repeating these studies to try and get a sense of how much is the peripheral nervous system regenerating and do we need to intervene. Brachial plexus injuries have taught us a lot about this. And this is a schematic of the brachial plexus, the plexus of nerves, or the network of nerves that lives right behind our collarbone that sends signals from the spinal cord out into the upper extremity. Oftentimes, patients in motorcycle accidents or other accidents are at risk of injuring this plexus of nerves. And it's a very common area that we have to go in and explore and intervene. If there is a little scar and nerve tissue disrupting the nerve signals, we often have to cut out that scar tissue and then graft to help that nerve recover. And then that nerve is off to the races. It's then got to regrow all the way from the nerve roots down to the target organ. So we know that nerves regenerate at about 1 millimeter per day or about 1 inch a month. So you can imagine that that's a long distance to go, and we have to be patient with the rehabilitation and helping our patients continue to train that nerve to stay active and ultimately help those signals grow. This is, again, some surgical pictures. This is what those sorts of neuromas or scar tissue can look like. Then we excise those and use cable grafts that we often harvest from other expendable nerves, like down there by the ankle, to help close that defect and allow the nerve to start to heal. This is another example of a case of a sciatic wound, a sciatic nerve injury from a gunshot wound that I'd operated on. And you can see that large, thick neuroma here that had to be cut out. And you can see this hard, woody appearance of the nerve. That's not how it's supposed to look. And we have to trim back that scar tissue and then harvest this cable sural nerve graft from the lower part of the leg, which is just a small sensory nerve. And we can use that to form a cable graft to fill the gap, okay? So that's traditionally how we manage peripheral nerve injuries, all right? It's a tried and true method. It's how we've dealt with a lot of traumatic injuries throughout the body. But nerve transfer has emerged in the past few decades as a unique and sort of elegant way to tackle some of the limitations of nerve grafting and the more traditional strategies of peripheral nerve injury. So this slide kind of summarizes some of the problems with the way we intervene now, and this will be relevant for when we talk about nerve transfer. So most nerve grafting, like I showed you with the brachial plexus up here, for patients who have proximal injuries, meaning a long way to go down to the hand or to other areas in the arm, that's quite a distance for those nerves to travel. In addition, we have to wait for the injury to kind of declare itself. We're waiting, watching to see what recovery does the patient get. We're getting those EMGs every few months. And we know that time is muscle, and I'll show a little bit more information about that. The longer we wait, the less the chance of a functional recovery. Similarly, we have to do these interposition nerve grafts. And even though we go under the microscope and suture them as best we can, it's a little harder for those nerves to go through those cables, and it slows down the recovery process. In addition, we can't really control how the little fascicles or bundles try and grow. They might get all jumbled up and not really make it through this graft in the correct order, and that can affect how much recovery is possible if it doesn't find its sort of sister end on the other side. So fortunately, though, our muscles and nerves are pretty resilient. This is out of some seminal work from Tessa Gordon in the 90s. It's some really a lot of interesting experiments on nerves, muscles and nerves after injury. And they found that even if you lost up to 70 or 80% of the nerve signal, if you're able to get the signals back to that muscle, it can really still recover and function almost as if you had 100% innervation. So but once you get past that 80% denervation mark or losing 80% of the nerve signals, then that function of that muscle really drops off. So we really want to intervene and optimize the level of nerve function that we can get. And nerve transfers are a way that we can help get signals to nerves faster before the muscle degenerates. So what is a nerve transfer? You can see on the bottom here, this is an example of a nerve that's been cut, injured, or severed. And the concept of a nerve transfer is that we're taking a healthy working nerve and using it as a donor to reinnervate or get signals back to that muscle. So this is a schematic of what that involves. So we cut the donor nerve or the healthy nerve distally, meaning closer to the target. The farther down we go on that nerve away from the spinal cord, we get more length on this nerve, and that gives us a bit more slack to swing it over to the recipient nerve. On the recipient nerve, we cut it proximally again to get more slack for that repair. We can create a tension-free repair here. We want a good size match of the two fascicles, and we want to allow these healthy donor axons in this end-to-end repair to kind of start to take over and send signals down to this muscle. Okay. Now, obviously, some principles apply to performing one of these surgeries. You want to use a redundant nerve. So you want to use a nerve that supplies a muscle or a muscle group that has multiple options for nerve innervation. So by taking this donor nerve, you're not downgrading that function. That's really key. In some situations, we have to make difficult choices or weigh the risks and benefits. So you want to at least try and sacrifice the less important one to serve as the donor. There are a lot of advantages to this, right? We can do this farther down in the arm, in the extremity, or wherever you're trying to do, or even in the leg, and you can get closer to the target site. We know that nerves can regrow only 1 millimeter a day, so the closer you are to the target, the less time there is that's required for recovery. In addition, you can kind of bypass or take a shortcut past the site of injury. So if you have a plexus injury up by the collarbone, doing a distal nerve transfer in the forearm, you're not worried about trying to regrow or heal through that scar tissue, and you're closer to the target. In addition, it's often a smaller dissection and only one repair site that you have to do. Conversely, though, if you're farther away from the brachial plexus, you're targeting specific nerves, and you may not be reinnervating a whole muscle group, but we can be very selective in how we do this. So here's an example of what that looks like, and this is a surgical video of a patient who had a weakness of elbow flexion of the biceps. And so what we're doing here is trying to take a donor nerve from the ulnar nerve to try and wire it over to the musculocutaneous nerve to help get elbow flexion back. And you can see part of the way we do these surgeries is we can stimulate the nerve during surgery and monitor to see what function are we observing and identify the nerves in the fascicles. So here you can see we're sort of identifying pronation and some finger function telling us we have the median nerve. We can move on and find the ulnar nerve. And then we're looking for the muscles the nerves, excuse me, that go to the biceps and brachialis that help with elbow flexion so that we can innervate them. So this is now under the microscope. We can then open up the nerve and look at the fascicles themselves within that nerve fiber and test them with stimulation to make sure that we're taking the correct fascicle. This is a video we published in Neurosurgical Focus with colleagues from the University of Pennsylvania. And here you can see stimulation of this fascicle is really going towards the hand function and finger function, so we don't want to hurt that. So we're going to look for one of the nerve fascicles going towards wrist flexion because we know that there's multiple nerve fibers that help with that function, and taking that as a donor won't downgrade this patient. So once we've sort of found that donor, we're going to look at our recipient, the nerve going to the brachialis muscle that helps with elbow flexion. We're going to cut that proximally, swing it over, and then get our donor from within the ulnar nerve to we're going to go distally towards, away from the spinal cord to get as much length as possible, section it there, and then swing it over to do our fascicular repair. Now, some keys about this sorts of repairs is you want to have a good size match. You want to have the ends not being under tension, and we use 8/0 or 9/0 nylon suture. So this is sort of smaller than the human hair thickness to reapproximate these nerve endings, and then we reinforce that with some fiber and glue. So this is just a good example of how we do nerve repairs and nerve transfer surgery, which will be relevant kind of when we talk about how we do this after spinal cord injury. So there briefly there's been a lot of literature on how we can maximize these sorts of techniques. Susan McKinnon has published on using two donor fascicles to maximize elbow flexion in a double fascicular transfer. For patients who have brachial plexus injuries, meaning that they have multiple deficits in the upper extremity due to injuries of the brachial plexus, we have multiple nerve transfer options to stabilize the shoulder and also help with triceps function. This is an example of that from the posterior approach, taking one of the triceps branches of the radial nerve to help with shoulder abduction, the axillary nerve, and then also using spinal accessory to stabilize the shoulder there. For some patients, the whole arm isn't working. And in that case, we have to be a bit more creative with our donors. And in some cases, we work with a multiple surgeon team to harvest and transfer whole muscles, even from the leg, the gracilis muscle, up to the arm to kind of fit in where the biceps isn't working. So this patient had a flail limb, and we use just this one small spinal accessory nerve to kind of power that whole muscle. So it's a really powerful technique to help get patients function back. And the way that this really works is reliant on this concept of cortical plasticity, that our brains can reorganize and adapt to learn how to make the best use of this transfer. You can think about it, we're sort of swinging one nerve over to a different recipient. So we now have to train our brains to activate one nerve to do now a different function. But fortunately, we know that our brains are very adept at this. And this can induce this concept of plasticity in the brain. And I have some sort of cartoons to help illustrate that. But this is very relevant for nerve transfer after spinal cord injury. So this is I won't belabor this, but this is some initial experiments in owl monkeys that showed that with sort of repetitive motor tasks or sensory stimulation, we can actually change the representation of these signals in our brain. So for fingers that are stimulated over and over again, the representation in the brain of that area gets bigger. Similarly, if you use some fingers or digits more than others, we can get that representation in the brain to grow. And that's the same concept that we see in nerve transfer. So some great work from Mariana Sokolovsky and Martin Malesi. They have some great drawings to illustrate their findings. But in the early days of doing nerve transfers, surgeons were transferring nerves from the chest wall that help us breathe over to the biceps to help with elbow flexion. And interestingly, they found that it would only work if the patient was breathing in. So they sort of got this terminology of the breathing arm. And in the early phase, the transfer really wouldn't work unless the patient was inspiring. But over time, the connection started to form on the brain side with plasticity to enable the patient to use the biceps without having to think about breathing. But when they sort of coupled inspiration with elbow flexion or bending at that elbow, they could get much more power of the elbow flexion. So this sort of illustrates that concept of cortical plasticity and how we can use that to our advantage to help with nerve transfers. And over the years, we've become a lot more informed about which transfers work and which ones don't, based on the representation of the different body parts and surfaces in the brain. If you have a much farther or a disparate cortical representation, so the tongue, nerves to the tongue or nerves to the elbow are kind of far away, those transfers didn't really work that well. But if we use some of those nerves to reinnervate facial function, those worked a lot better. Similarly, sometimes we have to take nerves from the other side And again, those were a lot more confusing for patients in rehabilitation to have good outcomes from. But nerves, cortical areas that are closer to one another definitely perform better. And this has implications, of course. If we've lost a lot of cortical representation from a whole arm injury, that's a lot more challenging to cover or reinnervate that whole area. Similarly, some patients who are in accidents also have traumatic brain injuries, and that may make it harder for the brain to relearn and adapt after these repairs. Okay, so that's a lot of preamble to now talking about nerve transfer after spinal cord injury. Now that we have a background on how have we historically managed peripheral nerve injuries, how do nerves regenerate, and how do nerve transfers work? Okay. So spinal cord injury and sort of this audience is certainly acutely aware that this is a very common, unfortunately, problem, and affects many, many people who are young, healthy, and active in their most productive years. So we want to do everything we can to maximize function. And over half of spinal cord injuries occur in the cervical spine. So it's a particular disease entity that we want to understand how we can develop new techniques to help these patients get function back. Now, interestingly, there's been a lot of study on health priorities of patients who have cervical spinal cord injuries. And above, in a lot of these papers, above all else, and even bowel and bladder function or even walking, the ability to use distal arm function has been rated very highly. So we focused a lot of energy trying to think about how can we get function down towards the hand and the distal part of the arm, the forearm. Um, so priorities in managing spinal cord injuries, of course, is to increase independent function as much as we can. And the mainstays of therapy, of course, are to optimize the current functional level. You want to prevent contractures, maintain joint mobility. You want to use orthoses or splints or supports to augment the function that we have. And then rehabilitation, of course, to strengthen the preserved functional muscle groups. But surgical interventions can help us improve the functional level and get beyond what the spinal cord injury has left us with. And this can traditionally has been done with tendon transfers, and now nerve transfers are another tool in our arsenal to improve the function, the level of function. So there have been some trials that have emerged within the past 5 years or so that were done over the last decade. I'll highlight one of them that was in JAMA, our Journal of the American Medical Association. This was a prospective series of adult patients with spinal cord injury. There were 22 patients that were followed and 60 nerve transfers that were done for these patients. And you can see that even some of them are done on the later end. The median timing was 21 months. We know, as I mentioned, traditionally in peripheral nerve injury, we think of 18 months or even 24 months as kind of the limit because time is muscle. But I'll go over in a little bit about why that window can be extended for patients with spinal cord injury because of the nature of the injury and how it differs from peripheral nerve injury. So in this trial, though, they had pretty good results. So we have a grading system that we use to grade muscle function, with 3 being MRC grade is Medical Research Council of anti-gravity or holding the muscle against gravity, and then 4 against resistance, and 5 being full strength. And for this bar is kind of in my way for elbow extension and so for finger extension, actually, the results were quite good in this trial, 70% and 79% of attaining greater than grade 3 function. For finger flexion and abduction, it was about 50% patients who got anti-gravity function, and there are a variety of reasons for that we can get into. But overall, very promising and encouraging results. Next slide here. So this is just an example of how some of the patients in this trial gain function throughout follow-up, even up to out to 2 years and beyond. And this is in flexor digitorum profundus, so finger flexion and thumb flexion. Similarly, for extension of the fingers and elbow extension, patients were seeing improvements over time. The triceps function in this trial, and we've seen it can be a bit more finicky. Historically, the way we try to innervate that triceps nerve from using an axillary branch didn't work as well. And so now there have been more sort of improved techniques to try and get that function to be better. But in this trial, it was less impressive. But, it can be really really powerful stuff. Instead of looking at bars and figures, this is kind of um, examples of videos from patients in this trial, getting sort of that finger extension and that sort of key pinch and grasping um, uh, to be functional. So just a word on nerve transfers compared with tendon transfers. For a long time, tendon transfers were the workhorse for reanimating muscle groups that were not, or functions, excuse me, that were lost after spinal cord injury. Nerve transfers have some distinct advantages. By regenerating a muscle, that muscle is already kind of mechanically designed to do that function. So rather than sort of using one tendon as kind of a pulley and swinging it over, which can be a bit uh, antagonistic, I guess is the way that we say, but it's sort of counterintuitive to try and activate an opposing muscle to try and do the opposite function, like using trying to think about activating your triceps to do your biceps. When you have you're reinnervating a nerve that's working the way that it was naturally designed to, that muscle, it can be a lot more functional and powerful. And sometimes, depending on how you plug these nerves in, they can send axons and signals to multiple muscle groups. Nerve transfers as well require smaller incisions and exposures, and we can keep patients only immobilized in a sling for shorter periods of time. But the real power is that we're not comparing one or the other, is that now we have another tool and we can use them in combination. Dr. Van Zyl in Australia has really been a pioneer of this work, and her citations there below. But she has a lot of case examples of using in different arms tendon transfers preferentially versus nerve transfers to give patients sort of different functional outcomes in different arms. And she's got some great patient stories of patients who've um, benefit from the tinnitus effect or the tendon transfer in for certain activities and use the nerve function, the nerve transfer to certain effect in others. So it can be really powerful in concert. So how do we go about evaluating patients for this technique? The International Classification for Surgical Treatment of the Hand in Tetraplegia, the ISCS, the International Classification for short, has been a way to kind of grade what muscles are working and what donors does that leave us with and what functions are we trying to get back. And so there's, in neurology and neurosurgery, we sort of operate a lot in the spine and we think primarily about the spinal cord level, but within that, there's a lot of gradations depending on which muscles are functional, and we can group these patients by which muscles are functional. And that helps us prioritize what functions can we get back. And obviously, the lower the level of your injury, the more options available, not just for nerve transfer, but if those fail, for any backup tendon transfer options. So here are kind of the priorities for reconstruction. Elbow extension is really key for increasing the level of function. It helps with not just overhead reach, but transfers, pushing a wheelchair, even regular daily activities, pushing blankets off, that can be really key. And it's sort of the first baseline step that we want to get back. For patients who are less than MRC grade 3, that's a real priority. Also, if there's less than any full range of motion. Wrist extension then is the second priority, and really your optimal donor, the best donor that you have, should be directed to the wrist extensors if, excuse me, if that is out and you don't have that available. For patients with lower level injuries, then we can sort of start to focus on pinching and grasping. And if depending on the donors available, you can think about hand opening and even hand intrinsics. So we can talk a bit about these through some examples. But evaluating and selecting patients based on a careful history and physical is key. Sometimes the level of spasticity can be important to assess. You can be fooled sometimes about how much function there is when patients have spasticity. You can sort of use that to their advantage, or as well as joint contractures. So you really have to be careful on how, on the surgical side, we evaluate each muscle group and test it and understand all the data available to us. Timing is also key. Like I mentioned, time is muscle. So the earlier we can do this, the better. For some types of injuries, actually, we have the benefit of time, depending on whether the nerve signals are originating from what we call the lesional injury in the spinal cord injury itself. And I can show some schematics of that in a little bit. But what the key assessment really is trying to evaluate the donor and recipient nerve health. You want to use as pure of a donor nerve as you can to get the best bang for your buck. And similarly, you want to have good stimulation, if possible, in the recipient nerve so that you know that that nerve is healthy enough to receive the signals that we're transferring over. If you don't have that, it can make the results less promising. And so we want to evaluate this as comprehensively as we can, excuse me, before surgery. So just one of the things we're doing at Mount Sinai is really leveraging our neuromuscular colleagues to do electrodiagnostic studies and evaluate our donor and recipient nerves. So here's kind of an illustration of spinal cord and the spinal cord injury. We have kind of this zone of injury. So you can imagine that if the axons that you're trying to use as a donor are originating from anywhere in that zone of injury, that makes the power of that nerve transfer weaker. Similarly with the recipients as well. And this great paper from Dr. Dibble and colleagues kind of illustrates that they had mixed outcomes if only one of the donor or the recipient was outside of the lesional zone, and they had poor outcomes if both were kind of involved in that lesional zone, and great outcomes if you were completely above and completely below. Excuse me. For infralesional injuries, so meaning the recipient nerve or the recipient function sits below the level of the spinal cord injury, that process of degeneration actually doesn't get kicked up or started. So it's kind of almost dormant. It's what we call an upper motor neuron injury. And in those cases, we actually have a longer window in which we can try and reinnervate those muscle groups because that process of Wallerian degeneration that I talked about in the beginning has not been triggered by the injury zone itself. So, this is a table from that paper just illustrating that if you're taking donors or recipients from the lesional zone, that the outcomes are a bit worse. But you can just sort of think about how we can use electrodiagnostics now, what we're doing to try and assess our donors and our recipients. If there are any injured donor axons, there's just less of a donor pool to get over to those recipients, and that can lead to a poorer recovery. And so we want to be really selective in how we prioritize here. So these are just some of the criteria that we use on our EMGs to evaluate for this. And we have, based on the literature, this algorithm like this to try and assess what are our priorities for nerve transfer. And if there are no good donors, should we just not waste time with that and move to tendon transfer to try and get function back as soon as we can. So I'll try and stay on time here. I know we're hitting the 30-minute mark, so I'll just close with a case example of a recent case just to try and illustrate how this electrodiagnostics that we have can be super helpful. This patient, a 30-year-old, after a motor vehicle accident, only 4 months post-injury, where we started thinking about reinnervation. Motor group 4, so pronator teres or forearm pronation was the most distal function that was preserved. And based on everything that I've sort of talked about, we have kind of an algorithm for how we can think about this. What nerve transfers can we try up first to get a sort of more elegant reconstruction that's a bit more natural and utilizes those good donor nerves that we have available. With group 4, we have the luxury of a few donors available, the supinator branch of the radial nerve, as well as the brachialis branch of the musculocutaneous nerve to help to get to the median nerve. And we have the option of giving those a shot. And these were the nerve transfers used in that trial that I mentioned. And if they fail, there are sort of backup tendon transfer options that can be used to try and achieve that same function if the nerve transfer doesn't work. So the goal for a patient like this would be that key pinch and release to get beyond that C6 level and get towards hand function. And we want to pick a donor nerve that doesn't cut any or burn any bridges for some of the tendons that we might want to use for a backup tendon transfer. But just as an added layer of security, we did our electrodiagnostic studies to try and identify, does this nerve look like a good donor? We know that the brachialis was in this case. Unfortunately for the level of injury for the supinator branch in this patient showed some partial axonal loss, which makes us a little bit more cautious. But since we're very early, we were hopeful then that the we're only 4 months from injury, that this could still be a good option, almost treating it like a peripheral nerve injury inside a spinal cord injury. So in that situation, we've sort of counseled and cautioned the patient on, maybe this second one may not work as well. But it really helped inform the surgical strategy because of the EMG or nerve conduction study that we have. We sort of knew we had to do a bit more extensive dissection on the recipient end. And this is just an example. It was sort of a unique case that we had more exposure than we normally would, um, to sort of see all the nerves and what they do. And you can sort of see here with the stimulator, we can identify the branches going to the two muscles that contribute to elbow flexion, the biceps and brachialis. And we have multiple sort of nerve loops here, identifying the anterior interosseous nerve that will be our recipient. Um, and we sort of have, in this case, had to dissect out the whole kind of median nerve, and including the pronator branches that help the forearm kind of turn over there. Here's a similar video on the other side, so everything's sort of flipped, but we can see the AIN sort of looped all throughout its course. Um, and we can take the stimulator and just kind of identify our donors and trace sort of all the way down to the AIN, and sort of showed at the end here, diving into to the pronator quadratus. So that's a little bit about how a very whirlwind tour of how we think about nerve transfers for spinal cord injury. I'll stop there, but I think it might be more helpful to answer any questions and have any discussion from the audience.
Can you hear me?
Yes. Hi there.
What is the relationship of what you're speaking about to stem cell? Is it
Right. So
completely different, or I mean, because I know
yes.
they don't do stem cells, they do it on the knees, but not on the back at the moment. And it was being tested, I think, in Atlanta and Miami for efficacy and safety.
Right, right. That's right. Yeah, this is a different reconstruction technique, separate from the stem cells, in which um, and I, we're taking a functional nerve and transferring it over. So we're not um, trying to start the regeneration process from scratch from a stem cell, which can become pluripotent, or try and um, treat the sort of zone of injury, but rather we're sort of bypassing the zone of injury, getting closer to the target, and trying to get signals, you can think of it that way, to the target muscle, which, you know, the we have a great track record of doing this in peripheral nerve injury. And that's why it's transferred kind of very seamlessly over into spinal cord injury, because we're just taking a lot of the techniques that we've learned from peripheral nerve injuries, and using them here in spinal cord injury very selectively. And we find that these nerves, because we know that they work and we've tested them, can be powerful donors of them, of those muscle groups that have lost innervation because of the spinal cord injury.
So it's more targeted at where the dysfunction is rather than the spine itself, right?
Exactly. Yeah. Even if there's a therapy that develops to try and address the spinal cord injury itself, well, then those signals still have to get all the way from there to the target muscle. And so this is a different strategy to just say, okay, we may not be able to reverse the damage that occurred at the level of the spinal cord, but we can still um, get down to those muscles that have been, let's say, cut off or isolated from the signals above coming from the brain.
So it's more, I mean, I don't mean to make it any less than it is, but I mean, it's more addressing the symptom rather than the problem.
Correct. Yeah. It's more about, well, it's more about addressing the or getting function, really. It's
Right.
we sort of think about, we've accepted for many years that we're stuck with a certain level of injury, based on the level of the spinal cord injury. If you're C5, C6, C7, that you just won't be able to get beyond that. If all you have is shoulder or proximal, then to getting that hand function, we're trying to think about, can we push to get that level of function back? And this applies, for some patients, they may present late, or they, may not have had access to any of these options early on. There still is a window of opportunity to try and get that function um, uh, to those muscles, even in a delayed fashion. So yeah, even if you miss that zone of opportunity to maybe put some stem cells or use some other therapy acutely at the time of injury. Does that make sense?
Yeah, it's interesting because the injury, at least for me, affects everything, the sensation in my feet, my hands, fingers, upper arm, everything. It's all over the place from the spinal injury.
Right.
Sensation in the feet, the picking things up, proprioception, everything is affected.
That's right. Yeah. And so we're in the early phases of this. And so right now focused on motor reinnervation and trying to um, it's one piece of the strategy, right? Just to get it to focus on motor reinnervation. And there are options for sensory as well, in some peripheral nerve injuries, but yeah, we can talk about that. But yeah, it's definitely not a panacea for all components of spinal cord injury, but a way to try and restore some function that was lost.
Mhm.
I see a few hands. I don't know if Ariana, you want to, or I can just try and uh,
Sure. Rolando.
Hi, hi, good afternoon. Can you hear me?
yes, I can hear you.
Okay, one, this was very insightful, so I appreciate Mount Sinai offering this. So I have like a two-part question. Is the recovery process painful or long, and is there severe scarring?
So the recovery process is shorter and less painful, excuse me, than for tendon transfers. It does depend, of course, on the which nerve transfer you're doing, but it's often generally what I have my patients in is there's absorbable stitches, so they don't need to be removed. You'll be in a sling just to sort of protect where the nerves were repaired for a couple weeks, and then there are no restrictions thereafter. So the pain can be from just the soft tissue incision, um, which is usually pretty tolerable. But we want to make sure, though, that once that period is passed, that we're ranging the arm, moving it so the joints don't get stiff, because that can be kind of painful. To answer your first part of your question about is it long, it is a long process depending on the level of injury, because then we have to then support that nerve as it regrows and heals and regenerates. So it has to sort of start to, it still grows at that 1 millimeter a day. So that's the part that we start to then support, focus on flexibility and tenodesis of the tendons. And then once we start seeing reinnervation, then the process focuses on what we call uh, cortical retraining, that part that I was referring to with the brain, in terms of even while we're waiting for that function to recover, just starting to think about activating one muscle to try and do another, and starting to get that program online, so to speak, in the brain. And that's a big part of this is staying motivated and finding candidates who are motivated to keep participating in that relearning process, because that's really the key part of the nerve transfer. It's not just the surgery that we do. It's relearning these functions. And we try and pick donors that are synergistic, that work with the way we already grew up and learned to use our brains to control our arms and legs. And so that's the strategy. Yeah.
Okay, and just like to add to that, and then one more
Mhm.
question so everyone else can get a chance. So that means OT and PT is involved, like at Mount Sinai or
Absolutely.
outpa Okay.
Yep.
And my final question is, just to be clear, does the donor nerve grow back?
No. So right. So the the key here is that we're taking a donor nerve that you won't notice you're missing, basically. So in the cases that I've shown, there might be two or multiple different nerves going towards the biceps or brachialis to help with elbow flexion. So taking one of those isn't going to downgrade that function. But instead, we're robbing Peter to pay Paul a little bit, is you can think of it that way. But we're using a redundant function. If there was
Thank you.
one
Oh,
nerve
mhm.
powering that muscle, we wouldn't do it or we wouldn't offer it. And we confirm and verify that at the time of surgery.
Okay, that was so helpful. Thank you so much.
Mhm.
Charisma.
Hi, can you hear me?
Yep.
Okay, so my question would be it's kind of like two-part as well. Um,
Mhm.
so could this be helpful for someone with a lower level, like a T12, and how?
So right now we're not there yet. It's mostly for upper extremity reinnervation is where the techniques currently are. Um, yeah, that's the short answer.
Okay, thank you.
Hmm. There will potentially be between spinal cord stimulation or other devices that are being developed for lower level injuries, but right now that's kind of in that zone where we just don't have a great transfer option. Part of it is we talk about the length of regeneration that has to occur and the level of injury that makes it challenging to find other donors that we can get to there. You know what I mean?
Yeah.
All right. Jonathan.
Okay. Doctor, I'm the father of a quadriplegic who actually was his initial treatment was at Mount Sinai. He has a C6. He's able to shrug his shoulders. He's able to pull when he gets strapped in with his biceps. And the OTs are getting him to rotate his forearm. So how do you is that the kind of connection that you're looking for this to work?
Just can you reframe your question one more time? So when you say the connection, is that are you asking if that's sort of what we're looking for in terms of candidates?
Yes.
Yes, and so yeah, that similar to the case I showed, that's a similar level of function to the videos I kind of showed at the end, with turning the forearm pronation being the sort of lowest level of function present there. But there are a lot of sort of factors that we then need to take into consideration to evaluate whether somebody's a candidate. So, including the timing of the injury, some of these testings that I'm talking about to evaluate what nerves could be potential donors, and then some, more details about the level of injury and the zone of injury and the mechanism. But yeah, that's sort of um, going back to that kind of schematic where we think about, this would be kind of a grade 4 or grade 5 based on what you're telling me. And then that means there may be some options for donors. If it's been a certain length of time, that may not be the case if in terms of donor nerves, and then there are backup tendon transfer options, but there's sort of a step ladder approach to try to think about what reconstruction options are there. Yeah.
He's approaching 2.5 years since the injury, but he had other extenuating circumstances, and the advent of him being able to do these things have come late in his healing. Uh,
Right.
but he continues to show improvement through OT and PT.
Well, that's great then. And yeah, and like I mentioned, that privilege time window can be extended depending on where the zone of injury is. And it's something that may be worth bringing up with your treating physicians, and we can maybe kind of go from there.
I'll talk to Dr. Escalon. Thank you.
Hmm.
All right. We have one more question from Luke.
Yep.
Hello.
Hi, I can hear you.
Hi. I'm a C4 level that was treated at Sinai this past fall and winter, so I'm very interested in this surgery. And I was just wondering if there was any negative side effects or anything pertaining to this surgery, I guess.
Yeah, so the risks really depend on it's really around downgrading function, right? Or risk of something not working. Um, and then burning bridges for later options, right? So I'm always reluctant on webinars to kind of comment on individual folks' cases, but for higher levels of injury, we can sort of see based on this step ladder, right, that it limits the number of donors available. And so then those donors that are there are really privileged, they're really important. And so if a transfer is done and it doesn't work, or then you run the risk of downgrading a certain function without any payoff. So that's where it makes the job harder.
Okay, thank you.
Mhm.
All right, seems like we have one more question from John Pierre. John Pierre.
Yep. Can you hear me?
Yeah.
Hi. I just had a question based on your nerve grafting. Now that are you only using it for motor function, or does the patient now have the ability to have sensory function over that area, or will it also still be able to react like with reflexes and stuff like that?
Yeah, no, we use for grafting and reconstruction and nerve transfer, we can do those for sensory functions as well. And in peripheral nerve injuries, that's what um we sometimes focus directly on that. And for some of these um injuries as well, we know that even nerves that we think about as pure motor nerves, they do have sensory fibers too. And so some of those connections can be formed afterwards. But we sort of right now are focused on motor reinnervation in terms of how we grade these in the past for spinal cord injury, right? That was always the focus on tendon transfers. But you're right. The next frontier will be now how can we apply this to improve sensory function after spinal cord injury?
Okay. Thank you.
Yep.
Walking isn't one of those functions that's improved, is it?
Not at this time, right? We're right now from this technique, the goal is to get donors to muscle groups in the arms that have lost function. But there are devices and others in development to think about stimulating the spinal cord to in conjunction with AI and sort of these sort of brain computer interface type things to that may be coming down the pipeline. But right now they're very experimental.
Mhm. Thank you.
Any other questions?
Very interesting.
No, we don't have any other questions, it looks like. So thank you everyone for joining us. And thank you again, Dr. Stephen Miranda, for this informative webinar.
Of course.
Yeah, so we will post the recording in our YouTube channels soon. And if anyone else has any other questions, you can email us. All right, thanks. Thank you, everyone.
Thank
Have a
you. Good day.
Thank you.
Bye-bye.